Hello friends, so let's review some endocrinology questions. We got 20 of them here. So question 1, a 61-year-old male with stage 3B small cell lung cancer presents to the ED with lethargy. Blood pressure is stable at 125/80. He's euvolemic. Physical exam is unremarkable. Labs are drawn and reveal, and these are all in standard US milligrams per deciliter units that you'll have on the USMLE, and you'll be given the normal values of all of these. Sodium is 121, potassium 3.8, chloride 103. Bicarb 25, BUN 22, creatinine 1.2, and glucose 133. Urine osmolarity is 355 milliosmoles per kilogram, which is elevated. CBC is unremarkable. In addition to admission, which of the following is the best next step in the management of this patient? A, fluid restriction. B, administration of 3% NaCl. C, normal saline bolus. D, hydrochlorothiazide. Or E, amiloride. Okay, so the answer here is A, fluid restriction. So this is a patient who is stable. He's got lethargy, but that's not a life-threatening condition as long as we're keeping an eye on him. He's euvolemic, but he does have a hyponatremia. And the fact that he has small cell lung cancer, the fact that he's euvolemic, the fact that he's got hyponatremia, and the fact that his urine osmolarity, most importantly, is still elevated, clearly indicates that this is a patient with SIADH, which we would expect with small cell lung cancer. I mean, small cell lung cancer plus hyponatremia should immediately make you think of SIADH. So when you have SIADH as a condition secondary to cancer, it generally comes on very slowly. And we know that it came on very slowly because he's stable, and 2, he's euvolemic. So if you had hyponatremia that came on quickly, let's say due to vomiting, due to pancreatitis, due to RTA, due to Conn syndrome, if you had a deficiency of mineralocorticoid, in that case you would have a quick hyponatremia. In other words, the patient would quickly develop the hyponatremia, and they would develop life-threatening symptoms, like, for instance, seizures, or they would be comatose. And in that case, we would want to correct their sodium quickly. If the patient develops the hyponatremia quickly, we need to treat it quickly. However, if they develop it slowly, then we can treat it slower. And the good thing about treating hyponatremia slower is that you don't run the risk of correcting it too fast. That's kind of logical. But what happens if you correct it too fast? You can cause swelling of the brain. And if you swell the brain, what happens is you can have central pontine myelinolysis, which is the primary complication of correcting sodium too quickly. So you don't ever want to correct sodium faster than 1 to 2 points, and by points I mean milligrams per deciliter, faster than 1 to 2 points per hour. You really want to correct it slower rather than faster if you can get away with it. So patients who are euvolemic and they're stable and they're well, you can correct it with just water restriction. If they have any significant symptoms, or if you know that they have any kind of condition where you may think they have lost their sodium quickly, like burns or vomiting or RTA or ketonuria or anything like this, generally they're going to be euvolemic, but you're going to want to treat them then a little bit faster. You'll treat them with fluid replacement and then 3% NaCl. But we try to avoid the 3% NaCl if we can. And in SIADH, it's very rarely needed. So in this case, we'll need water restriction. That's it. But you will need to admit the patient to keep an eye on those sodium values. Okay, question 2. A 48-year-old woman presents for her annual checkup. Her medical history includes hypertension, which is controlled, and psoriasis. She denies any new complaints. Physical exam reveals a small nodule on the left side of the thyroid. Thyroid function tests are drawn and reveals a TSH of 2.1, which is normal. Which of the following is the next best step in the management of this patient? A, reassurance, B, RAI uptake scan, C, fine needle aspiration, D, surgical removal, or E, methimazole. Okay, the answer here is C, fine needle aspiration. So you may be wondering, why are we not doing a iodine uptake scan, considering that that this is a patient who has a thyroid nodule? And the fact is, you can do an RAI uptake scan, and that can show you if the nodule is a functioning nodule, or in other words, a hot nodule, or a non-functioning nodule, which is a cold nodule. However, you don't need to do the scan to make the diagnosis. And what the diagnosis we're concerned about here, because the patient has a normal TSH, because the patient does not have any signs of a toxic nodule, which would be signs of hyperthyroidism, what we're concerned about is cancer. And so, I mean, this woman is in the right age group. She's a woman. She's got risk factors for thyroid cancer. And so what we want to do, what's most important to do, is a fine needle aspiration. And we don't need to know, I mean, we know where the nodule is because we can feel it, but we don't need to do any kind of scan because we do the fine needle aspiration under ultrasound guidance. So fine needle aspiration is the best first step after you've located a nodule and you know that it's not a toxic nodule. And by toxic nodule, I mean a nodule that's causing the patient to have hyperthyroid symptoms or a depressed TSH. Now, an RAI uptake scan can be done, but usually it's going to be done by a surgeon before they do their actual surgical removal. And that would be, for instance, if you had a toxic nodule. So fine needle aspiration is the best next step. Question 3. 29-year-old woman presents to the ED complaining of severe headache and anxiety. She denies any recent drug use or alcohol consumption. Blood pressure is 195 over 115, heart rate 110, respirations 18, temperature 98.7 Fahrenheit. EKG reveals sinus tach. Hydralazine is administered, but the blood pressure remains elevated at 193 over 115. Plasma metanephrines come back elevated. Which of the following is the best next step in the management of this patient? A, labetalol, B, esmolol, C, prazosin, D, phenoxybenzamine, or E, emergent surgery? And the answer here is D, phenoxybenzamine. So what does this patient have? She's got a really high blood pressure, she's got a severe headache, and she has a blood pressure that is not responsive to traditional antihypertensives. And then she's got those plasma metanephrines that come back elevated, which is the dead giveaway. She's got a pheochromocytoma. It's rare. Pheochromocytomas are extremely rare. They're less than 1% of emergent hypertensive cases. However, they're important to know about because they have a high mortality rate, because if they're not treated quickly enough, they'll lead to death. I suppose that was kind of a redundancy. But anyhow, you need to know what these look like. But they're very obvious because generally on the USMLE, you'll be given the plasma metanephrines coming back elevated. And another thing is high blood pressure in conjunction with a headache, particularly in a young patient. Young patients don't just get malignant hypertension. So if you get a young patient with severe hypertension, you better be thinking of pheochromocytoma and getting those plasma metanephrines. Luckily here, the plasma metanephrines were already ordered. Now, what do you use to lower the blood pressure? You have to use alpha inhibitors. So you cannot use beta blockers. If you use beta blockers, you're actually likely going to cause the patient to die. So beta blockers will actually cause the blood pressure to go up even more. So labetalol and esmolol are both beta blockers. As far as what kind of alpha blocker we want to use, well, I mean, an alpha blocker is better than a beta blocker. However, a non-selective alpha blocker would be the best. And prazosin is a selective alpha-1 blocker, and phenoxybenzamine is a non-selective alpha blocker. So phenoxybenzamine or phentolamine, those are both good choices for pheochromocytoma. As far as emergent surgery, well, yes, we will eventually do surgery on this patient. However, you don't ever do emergent surgery on a pheochromocytoma because you have to get the blood pressure down and stabilized before you can actually remove the tumor itself. So you'll use an alpha blocker and then a beta blocker, and then you can go ahead with surgery. Remember alpha before beta, just like in the Greek alphabet. Okay, so we got the same patient. We've administered IV phenoxybenzamine, and her blood pressure drops to 135/90. Good. Labs return and reveal a serum calcium abnormally elevated at 11.4 milligrams per deciliter. Which of the following is the most likely diagnosis in this patient? A. MEN1 syndrome, B. MEN2A syndrome, C. MEN2B syndrome, D. hyperthyroidism, or E. renal artery stenosis. And the answer here is B. MEN2A syndrome. So you should memorize these. A lot of the USMLE loves to give these questions out, and really, if you just memorize them, you'll get the question right because they're really just trivia questions. So remember, with MEN1 syndrome, you've got the 3 Ps: pituitary, parathyroid, and pancreatic. With MEN2 in general, you have pheochromocytoma and thyroid cancer. With A, you have parathyroid hyperplasia, like in MEN1. And with MEN2B, you've got a marfanoid body habitus and mucosal neuromas. So with both of the MEN2 syndromes, you've got thyroid carcinoma and pheochromocytoma. But 2A, you've got parathyroid hyperplasia. 2B, you've got the body habitus and mucosal neuroma. Both in MEN2A and MEN2B syndrome, if they're diagnosed with that, then you're going to do a prophylactic total thyroidectomy because 100% of these patients go on to develop medullary thyroid cancer, which is very deadly. So we'll just remove the thyroid even without thyroid symptoms. Okay, so the parathyroid hyperplasia here is what caused her calcium to be elevated. Okay, question 5. 16-year-old male presents to the clinic with his concerned mother. That's never good. She's worried because he doesn't seem to be growing like all the other boys in his grade. Physical exam reveals an apparently healthy boy at 6'5", 185 pounds, seems to be growing to me, with sparse pubic hair and a large areolar diameter. His arms are long and his hip girdle seems somewhat wide. Now you can see why mom's concerned. The testes are firm, 1.2 centimeters in diameter. Penile length is 3.5 centimeters flaccid. Which of the following is most likely to be found in this patient? A. Anosmia, B. Webbed neck, C. 45X0 karyotype, D. 47XXY karyotype, or E. low serum LH. And let me add here that this patient also had difficulty with learning how to read in grade school. And he's a couple grades behind with his reading, but he's fine with math. Okay, the answer here is 47XXY karyotype. So this is a patient with Klinefelter syndrome, and there's 2 things to think of when you have a patient such as this patient who's 16 years old. By all means, he should be in puberty, well into puberty, who is not developing secondary sex characteristics. Clearly, he's growing. He's 6'5", he's quite tall, but he's not developing the secondary sex characteristics, the sex characteristics that we would expect in a man. He's got sparse pubic hair. He's got a large areolar diameter. Well, that's strange. That should happen in women. He's got long arms, and his hip girdle is wide. That happens in women too because they need to have a wide hip girdle to deliver a baby. He's also got a micropenis, and he's got small testes. So this is all consistent with Klinefelter syndrome. Plus, what I added there, the fact that he had difficulty with reading, that's very, very, very common in Klinefelter syndrome. So anosmia would be could be something that you may see in a patient that has delayed puberty. However, that would be in Kallmann syndrome. And with Kallmann syndrome, generally you don't get the learning delays, and they're not quite as tall as patients with Klinefelters. And also in the USMLE, if it's a Kallmann's patient, you'll be given anosmia in the question, because that's such a present symptom. Webbed neck is a feature of Turner syndrome, which happens in phenotype girls. And that's also the 45X0 karyotype. So both of those are Turner syndrome, and that's kind of like the girl equivalent of Klinefelter syndrome. So in Turner syndrome, where a normal girl would be XX, they only get one X chromosome. Klinefelter syndrome, as mentioned, it's the XXY karyotype, so these are boys that got an extra X chromosome. And low serum luteinizing hormone would be a hypogonadotropic hypogonadism. Okay, so these are some features that you would see in a patient with Klinefelters. So, of course, the lack of pubic hair and facial hair, gynecomastia, along with that increased areolar diameter, very long arms, testicular atrophy, small penis size, and long legs. Look at this patient here. Very, very, very long legs. He's been a great swimmer. But look at that hip girdle here. You see he's very, very thin, but he's got a wide hip, very wide hips. He's got that typical hourglass shape that you would see in women. So this is very unusual for a boy. This patient, in fact, does have Klinefelter syndrome. And then this is a karyotype. This is the most accurate diagnosis for Klinefelters. This is the most this is the gold standard. Okay, so we got the same patient here. Which of the following is the best next step in the management of this patient? A, leuprolide, B, recombinant growth hormone, C, intramuscular testosterone, D, clomiphene, or E, anastrozole. All right, so the answer here is C, intramuscular testosterone. So obviously this patient doesn't have any problems growing. He's 6'5", 185 pounds. So we're not giving growth hormone. Okay, leuprolide is a medication that actually will decrease LH and FSH production, and we don't want to do that because we want this patient we want his testosterone level to increase. We want him to develop man sex characteristics, presumably male sex characteristics. So we want him to have testosterone. Leuprolide is not going to help generate testosterone. Really, the only way we can get patients with Klinefelter syndrome, we can get them to have testosterone, is to give them testosterone. So intramuscular testosterone is the best choice. Clomiphene it's a selective estrogen receptor modulator that will increase LH and FSH production, but it does not increase testosterone. And anastrozole is an aromatase inhibitor that would increase your testosterone, but it doesn't boost testosterone production, which is what we want to do. Anastrozole would simply block conversion of testosterone to estrogen. So in patients with Klinefelter syndrome, to get these boys to develop secondary sex characteristics, we need to give them testosterone because they're not producing enough. Now, these patients with Klinefelter syndrome will need testosterone throughout their lifespan in order to maintain their secondary sex characteristics and oftentimes to keep their libido. So they'll need ongoing care with testosterone. And you're not going to be doing this. This will be done by a pediatric endocrinologist. But you need to know that for Klinefelter syndrome, they need testosterone. Okay, question 7. A 42-year-old woman presents to your clinic complaining of difficulty losing weight. She says that she's been exercising and closely monitoring her diet. Her medical history is significant for hypertension, which was diagnosed at her last visit 3 months ago. Today, her blood pressure is 130/90. Physical exam reveals an overweight woman with a BMI of 29.8. You should know that BMI should be under 25. Anything above that is overweight. Anything above 30 is obese, with a conspicuously increased distribution of fat over the abdomen. You note faint violaceous striae and what appears to be periorbital edema. Her current medications include hydrochlorothiazide. TSH is 1.7, which is normal. Which of the following is the best next step in the management of this patient? A, serum cortisol level. B, high-dose dexamethasone suppression test. C, low-dose dexamethasone suppression test. D, serum ACTH level. Or E, a CT of the abdomen. Okay, so the answer here is a low-dose dexamethasone suppression test. So this is a patient who has signs and symptoms and a history consistent with Cushing syndrome. So here's the little tree that I gave you in the hyperadrenalism lecture. Now, if you suspect Cushing syndrome, then the best initial diagnostic step is a low-dose dexamethasone suppression test. Why is that the best first step? Because in any patient who is secreting excess cortisol, a low-dose dexamethasone suppression test will not suppress it. And a patient who has a normal cortisol, then the low-dose dexamethasone, that will suppress their cortisol. So if they have a suppressed or normal cortisol, less than 1.8 micrograms per deciliter, you don't need to know that level for the test. If they have a suppressed or normal cortisol level with the low-dose dexamethasone suppression test, then they do not have Cushing syndrome at all, ever, 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 ever. If though they have an elevated cortisol despite your low-dose dexamethasone, remember dexamethasone suppresses cortisol production. If they still have an elevated cortisol after the low-dose dexamethasone suppression, they do likely have Cushing syndrome. And remember, Cushing syndrome is any cause of cortisol secretion, excess cortisol secretion. Now, you have the option of doing a 24-hour urine-free cortisol, and what that is because there are possible false positives when you do a low-dose dexamethasone suppression test. Most of the time they are true positives, but sometimes you can get a false positive. A 24-hour urine-free cortisol is more accurate than a low-dose dexamethasone suppression test. However, the best initial test is the low-dose dexamethasone suppression test because it's an easier, faster test to do. And it's very reliable. If there's anything that makes you think that this patient may be at risk for false positives, which we have no reason to think so in this patient, we weren't given any reasons, then you can do a 24-hour urine-free cortisol, but you don't need to do that in this patient. So a low-dose dexamethasone suppression test is always the best initial diagnostic step in a patient where you suspect Cushing syndrome. After you get the low-dose dexamethasone suppression test and you still have elevated cortisol, then you do a high-dose dexamethasone suppression test. And what a high-dose dexamethasone suppression test does is it weeds out the pituitary adenomas from the other cause of Cushing syndrome. So in a high-dose dexamethasone suppression test, that will turn off the cortisol production in pituitary adenomas. So you'll have a reduction in plasma cortisol after you've given the high-dose dexamethasone. If you don't have a response, then you know that it's either an ACTH-secreting tumor or an adrenal neoplasia. ACTH-secreting tumors secrete ACTH, which stimulates the production of cortisol. So that's secondary. Adrenal neoplasias directly secrete cortisol. So what you do then, if you have no response to the high-dose dexamethasone, you know it's either ACTH secreting or adrenal neoplasia, then you just get the ACTH level. In patients with an ACTH secreting tumor, then you know they've got a high ACTH level. With patients that have adrenal neoplasias, they're going to have a low ACTH level because they've got the cortisol coming back and giving negative feedback to the pituitary secretion of ACTH. So they'll have very, very low ACTH levels. So in those patients, you know they have adrenal neoplasias. And in patients with adrenal neoplasias, then you will get the abdominal CT to visualize it. Patients with ACTH secreting tumors, those tend to be in the chest, so you'll get a chest CT. So in this patient, you get a low-dose dexamethasone suppression test. That's the first test we get when we suspect Cushing's syndrome. Remember, Cushing's syndrome is anything that causes hypercortisolism. Cushing's disease is strictly a pituitary adenoma, which is in the realm of Cushing's syndrome. Okay, question 8. A 20-year-old male presents to the ED via EMS. Paramedics say that he collapsed during his college physics lab and had what appeared to be a tonic-clonic seizure. History is unknown. Vitals are stable. Physical exam reveals an unresponsive male with generalized muscle stiffness. 5 milligrams of lorazepam were administered in the ambulance. Labs reveal calcium of 8.1, which is low. CBC shows a hemoglobin of 9.4, hematocrit of 28.1, white blood cell count of 9.4, platelets of 234, and a total bilirubin of 2.1, which is elevated. Which of the following is the best next step in the management of this patient? A. Repeat 5 milligrams of lorazepam. B. Phenobarbital. C. Vitamin D replacement. D. Calcium gluconate, or E. IV fluids followed by hydrochlorothiazide. All right. And the answer here is D. Calcium gluconate. So this is a patient who has hypocalcemia. You know that because his calcium level is 8.1. Seizures are a possibility and certainly a very common presenting complaint, for that matter, with hypocalcemia. Remember what calcium does. It stabilizes membranes. It stabilizes the membranes of the myocardium. It stabilizes all cell membranes. So any patient who has hypocalcemia is going to have neuronal hyperactivity. So things like seizures. With patients who have hypercalcemia, they will have neuronal hypoactivity. So they'll have things more like sluggishness or lethargy or coma. So this is a patient who clearly, with his low calcium and with a possibly life-threatening condition, needs to have his calcium replaced. So you would give calcium gluconate. We don't need to repeat the 5 milligrams of lorazepam unless he goes back into a tonic-clonic seizure, but certainly we need to treat the underlying cause first. So he's already been given the lorazepam and he's no longer in tonic-clonic seizure. Phenobarbital is given if he's not responsive to the lorazepam and seizure. But what you should know here is that because he's got a low calcium and he's got symptoms of hypocalcemia, you have to replace the calcium. Okay, and then IV fluids followed by hydrochlorothiazide, you should know that's the treatment for hypercalcemia. Okay, a 39-year-old male presents to the ED with sharp right lower quadrant abdominal pain. It's continuous and it's been going on for the last hour. It does not radiate. He rates it as a +9 out of 10. Vitals are stable, psoas sign is positive. Abdominal CT is consistent with acute appendicitis. His labs show a sodium of 131, potassium of 5.2, chloride of 107, bicarb of 30, BUN of 24, creatinine of 0.9, and glucose of 114. On CBC, he's got a hemoglobin of 12.2 with a hematocrit of 37.1. White blood cells are at 13.1, and his platelets are 314. He's admitted and placed on NPO for surgery. However, prior to surgery, his blood pressure drops to 75/40. Fluids are administered, but his blood pressure only rises to 83/55. Which of the following is the best next step in the management of this patient? A, 3% NaCl administration. B, a normal saline bolus. C, fludrocortisone. D, methylprednisolone. Or E, epinephrine. And the answer here is D, methylprednisolone. So here you have a patient with acute stress. He's got an inflammatory reaction going on. And he also happens to have a hyponatremia with a hyperkalemia and a metabolic alkalosis. Well, he's got an elevated bicarb. I guess we don't know that he's got alkalosis because we don't know his blood pH, but he possibly has metabolic alkalosis because his bicarb is high. So this hyponatremia plus a hyperkalemia, when you have a patient that has those two things and they're not on diuretics, you are thinking hypoadrenalism. So we don't know necessarily the cause of this patient's hypoadrenalism, of this patient's low cortisol, and really it doesn't matter. What matters is that we have to treat his hypoadrenalism. And a lot of times, patients with hypoadrenalism can go subclinical until they get some kind of acute stress, and then they develop this significant drop in blood pressure and life-threatening conditions. So the fact that he's got appendicitis is likely what triggered his hypoadrenal crisis. So likely what he has is Addison's disease, but we don't necessarily know that because it could be any cause of hypoadrenalism. What matters, though, is that we recognize he's got a low sodium, a high potassium, and a high bicarb. That's consistent with hypoadrenalism. And so, because he's got this low blood pressure and we're giving him fluids and it's not responding, we've got to give him steroids. And what we're going to give him is glucocorticoids, and that would be methylprednisolone. Fludrocortisone certainly is something that he'll eventually need if he has Addison's disease, but that is not that doesn't replace cortisol. It replaces aldosterone. So we don't use fludrocortisone. 3% NaCl administration, that would be to correct hyponatremia. We're not doing that here. We're trying to save this patient's life, so not that. Normal saline bolus, we already tried that. It didn't work too well. And epinephrine, that's not right because we know this patient's got hypocortisolism. So we've got to treat his hypocortisolism. And we're going to give him methylprednisolone, 100 to 300 milligrams, and then we're going to order a cortisol level, and that cortisol level, if it comes back low, then we know that we've got to continue to treat his hypocortisolism. And that's going to be important because before he goes into surgery, we're going to need to give him more cortisol, more methylprednisolone. So the answer here is D, methylprednisolone. We are treating his Addisonian crisis. Okay, question 10. A 27-year-old male presents to your clinic complaining of loss of vision. He says it came on slowly, and he saw his optometrist, who was bewildered and suggested he see his MD. Physical exam reveals visual field deficits in the lateral fields in both eyes. There are no other symptoms present. Which of the following is the best next step in the management of this patient? A, prolactin level, B, TSH, C, a CT of the head, D, reassurance, or E, referral to ophthalmology. And the answer here is A, prolactin level. So a prolactin secreting adenoma is the #1 cause of pituitary adenomas. Pituitary adenomas are the #1 cause of bitemporal hemianopsia in younger patients. So this is what we want to have. We want to have a prolactin level because a prolactin level would show us if we have a prolactinoma, and a prolactinoma is what we suspect because he's got bitemporal hemianopsia, which is visual field deficits in both lateral fields. So a TSH level is not correct because that's for thyroid problems. A CT of the head, eventually, yes, we will get that, but a prolactin level is what we want first. CTs are more expensive, and they expose the patient to radiation. So we want to have a prolactin level first. Prolactinomas in men tend to be macroadenomas, and so they're very likely to cause these bitemporal hemianopsias. Reassurance, no, because we want to see if he's got a prolactinoma, and referral on the USMLE is never the right answer. Okay, question 11. A 47-year-old woman presents to your clinic for a follow-up on her fasting blood glucose results. She's had 2 readings, which were 131 and 129 milligrams per deciliter. She has a medical history of hypertension, which is controlled with hydrochlorothiazide. Physical reveals a mildly overweight woman with a BMI of 27.9, but no other significant findings. In addition to diet and exercise, which of the following is the best medical therapy for this patient? A, insulin therapy, B, metformin, C, rosiglitazone, D, glipizide, or E, exenatide? And I'm just going to add here that this patient has a hemoglobin A1C of 7%. So the correct answer here is going to be B, metformin, and you should be aware that metformin is the cornerstone of medical therapy for type 2 diabetes. So insulin therapy, the only time we start, okay, first off, how do we diagnose this patient with type 2 diabetes? Well, we know she's got type 2 diabetes because she has had 2 readings which were above 126 milligrams per deciliter, and those are fasting blood glucose levels. So because of that, she's stamped with type 2 diabetes. Now, the rules are the most recent the most recent recommendations are if the patient has a actually I'm forgetting this now. If the patient has a A1C of less than 7.5, then we start them on monotherapy. If it's 7.5 to 9, we start them on dual therapy. And if it's greater than 9 without symptoms, it's triple therapy. And greater than 9 with symptoms, and by symptoms I mean, for instance, if she were to have paresthesias, if she were to have end-stage renal disease, diabetic renal disease, and so forth, then we would start her immediately on insulin therapy. I don't know about those exact numbers; they just came out recently. So check my diabetes lecture because I had it fresh on my mind. There's something like that, 7.5 to 9, I think is the cutoff. Either way, if we're going to start a patient with diabetes on a medical therapy, and it's not insulin because she doesn't have any diabetes symptoms as far as diabetic neuropathy, diabetic retinopathy, etc., then metformin is the first drug we go to. Metformin is the cornerstone. Rosiglitazone is a thiazolidine dione. That could be a good add-on therapy if we needed to use 2 drugs. Same with glipizide and exenatide. Glipizide is a sulfonylurea, and exenatide is a GPP1 agonist. So we don't go right to insulin therapy in this patient because she doesn't have the end stage symptoms of diabetes. Okay, 65-year-old man presents to your clinic complaining of numbness and tingling of his feet. His medical history includes hypertension, which is controlled with captopril, and type 2 diabetes mellitus, for which he takes metformin and exenatide. Physical exam reveals decreased pinprick sensation in his feet bilaterally, along with a small ulcer on his right heel, otherwise unremarkable. Hemoglobin A1C is elevated at 9.5%. Which of the following is the best next step in the management of this patient? A, gabapentin, B, carbamazepine, C, add a 3rd oral antihyperglycemic drug, D, CT of the spine, or E, switch to insulin therapy. All right, I probably gave you some hints on the last explanation here. Answer here is going to be to switch to insulin therapy. So he has symptoms of diabetic neuropathy, and so therefore we want to switch him to insulin therapy to get the best control of his glucose. So gabapentin and carbamazepine would be fine drugs to treat the symptoms of diabetic neuropathy, but to treat his diabetes, we want to treat his blood glucose level, we need to switch him to insulin therapy. That's first and foremost. Okay, so here we go. Yes, okay, so I was right. So 6.5 to 7.5, we give them monotherapy. We start with metformin, and then with with A1C, we at 7.6 to 9, we do dual therapy. And if they're not responsive to that, we can start them on triple therapy. And if their A1C is greater than 9 and they've got no symptoms, then we start them on triple therapy. If they've got symptoms, then we put them on insulin. Okay. Question 13. A 56-year-old man presents to your clinic complaining of weight gain. He is presently being treated for type 2 diabetes mellitus. Over the last 6 months, his weight has increased from 215 pounds to 250 pounds. His current diabetes regimen includes metformin and glipizide. He says that his blood glucose levels are well controlled. His hemoglobin A1C is 6.5, clearly reflecting that. Which of the following medication switches would be most appropriate in this patient? A, stop both metformin and glipizide and start insulin. B, stop glipizide and start pioglitazone. C, stop metformin and start pioglitazone. D, stop glipizide and start exenatide. E, stop metformin and start exenatide. And answer here is D, stop glipizide and start exenatide. So this patient has weight gain from his regimen of diabetes. And so what we have here is metformin and glipizide. Metformin is not associated with weight gain. Glipizide, as a sulfonylurea, is associated with weight gain. So we want to get him off his glipizide. So that's going to eliminate C and E. We have no need to switch him to insulin. And as a matter of fact, we don't want to do that because his hemoglobin A1C is under good control. What will help you lose weight in diabetes? It's going to be exenatide and liraglutide. So the GLP-1 agonists and DPP-4 inhibitors are both drugs that are, they're expensive, but they're much better than the sulfonylureas and thiazolidine-diones because they're safer. With the GLP-1 agonists, it increases weight loss, so you have weight loss with GLP-1 agonists. With DPP-4 inhibitors, you don't get the weight loss. But the important thing to remember is that sulfonylureas will cause weight gain, and GLP-1 agonists like exenatide and liraglutide, those cause weight loss. So if you have a patient that has gained weight and they've got good control over their blood glucose, you can take them off a sulfonylurea and put them on a GLP-1 agonist. Now, the thing with GLP-1 agonists are that they have to be taken subdermally, so that's something that patients have to get used to. But in general, the patients will be very, very happy to take these drugs because they're very effective with weight loss. Okay, I wanted to go back to one thing here. With this woman here that we put on metformin, I just wanted to add, and it has nothing to do with the question, but the fact that she is controlled with her hypertension on hydrochlorothiazide, now that she's been diagnosed with diabetes, we want to take her off hydrochlorothiazide and put her on an ACE inhibitor because whenever we treat hypertension in conjunction with diabetes, ACE inhibitors are the best because they're renal protective. So use like lisinopril or captopril. Okay. So, question 14. A 17-year-old female presents to the ED via EMS. Her mother called 911 because her daughter was delirious and sweating. Vitals show blood pressure of 135/90, heart rate 115, respirations 20, temperature of 101.4 Fahrenheit. EKG reveals sinus tachycardia. Physical exam reveals an agitated and confused patient in distress. Her face is flushed and there is excessive sweating. She has a mild goiter. IV fluids are started and propranolol is administered. Which of the following is the next best step in the management of this patient? A, IV methimazole. B, IV propylthiouracil. C, emergent thyroidectomy, D, radioiodine ablation, or E, nifedipine? All right, the answer here is going to be B, IV propylthiouracil. So this is a patient who's got thyroid storm, and what you may have been thinking about is, aren't methimazole and propylthiouracil both equal? And the fact is, yes, they are equal if we're treating hyperthyroidism. But if we're treating thyroid storm, propylthiouracil is preferred. So use PTU if it's thyroid storm, but if it's a patient with just plain old hyperthyroidism, you can use whichever one you want. Emergent thyroidectomy, there really isn't any such thing. Radioiodine ablation will eventually be good in this patient, but of course we need to treat the thyroid storm. That's the first thing we do. Actually, the first thing you do was given here. You're going to administer propranolol. That's to help with the tachycardia, because one of the leading causes of death in patients with thyroid storm is the tachycardia causing a arrhythmia. So we want to administer propranolol first, but then we'll go right into giving propylthiouracil to treat the thyroid storm. Okay, 26-year-old woman, G3P3, presents to your clinic. She recently gave birth to a healthy baby girl via normal vaginal delivery. Her pregnancy was uncomplicated. She has had difficulty breastfeeding, which she says happened after both of her previous pregnancies, and she attributes it to her small breast size. She is concerned, however, because her hair has thinned out and she's gained 20 pounds since delivery. She also has not menstruated yet. Physical exam is unremarkable. Which of the following is the most likely mechanism of disease in this patient? A, herniation of arachnoid mater into suprasellar space. B, lymphocytic infiltration of the thyroid. C, hemorrhage into the pituitary gland. D, severe fibrosis of the thyroid gland. E, ischemic necrosis of the pituitary gland. Right. So the answer here is E, ischemic necrosis of the pituitary gland. So this is a patient who has hypothyroidism. She's got thin hair. She's gained 20 pounds. And she's got signs of hypothyroidism, I should say. And she's got signs of low LH and FSH because she has not menstruated, and it's 6 months after her delivery, and she's not breastfeeding. Normally, a woman should start to get her period no more than 3 months after delivery. So with both of those signs, low thyroid hormone level and possibly a low LH and FSH level, that's suspicious for Sheehan syndrome. And Sheehan syndrome is ischemic necrosis of the pituitary gland. Herniation of arachnoid mater into suprasellar space, that would be empty sella syndrome. That tends to happen in heavier women, but it tends to be asymptomatic. Lymphocytic infiltration of the thyroid is subacute thyroiditis. I suppose it could be also Hashimoto's thyroiditis, but that would not explain the fact that this happened acutely after pregnancy and the fact that she's not menstruating now. Well, I suppose it could explain that she hasn't menstruated yet, but this happened acutely after pregnancy, and she's had difficulty breastfeeding. Hemorrhage into the pituitary gland, that's pituitary apoplexy. That's acute and life-threatening, so that's definitely not in this patient. Severe fibrosis of the thyroid gland, that's Riedl's thyroiditis. And ischemic necrosis of the pituitary gland is indeed what we have here. That's Sheehan syndrome. So think Sheehan syndrome when you've got signs of panhypopituitarism, so difficulty breastfeeding, no menstruation, prolonged, long after pregnancy, signs of hypothyroidism. When it's after pregnancy, you think Sheehan syndrome, and that's ischemic necrosis of the pituitary gland. Okay, 51-year-old male presents to the clinic complaining of generalized pain over the last several months. You've known this patient for some time and noted a distinct change in his appearance. His jaw has become more prominent, and when he smiles, his teeth are separated. He is also not wearing his wedding ring. He says he and his wife are getting along fine, but his ring stopped fitting him. Based on these findings, which of the following initial diagnostic tests would be most relevant? A, IGF-1 levels, B, CT of the head, C, testosterone levels, D, GH levels, or E, GHRH levels. All right, so this is a patient who has acromegaly. So we want to get IGF-1 levels on this patient. IGF-1 levels are the first test you're going to get when you suspect acromegaly. Why do we think this patient has acromegaly? Well, he's got a enlarging jaw, and that's very characteristic of acromegaly. So two things you would see facial-wise in acromegaly is coarsening of the facial features, so a more prominent jaw. And when you get when the jaw enlarges, you actually will get this separation of the teeth. So those are two things that are highly correlated with acromegaly. Another thing that fits with acromegaly here is the fact that his ring doesn't fit him anymore, and that's because of the fact that his fingers are enlarging. So in acromegaly, the bones actually widen. And that's different from a growth hormone secreting tumor in a child where they would have gigantism. They would their bones get longer, so they get taller. So in patients where we suspect acromegaly, we're going to get IGF-1 levels. If they come back positive, then we'll get a growth hormone levels with glucose suppression. Question 17. A 33-year-old woman presents to your clinic complaining of difficulty managing her weight. She's tried to manage her diet and exercise, but remains at a BMI of 30. On physical exam, you see an obese woman, mild facial acne, no goiter, truncal obesity, and pubic hair extending up her abdomen past the navel. Pelvic exam reveals no masses, but while you're examining her, she says that her menstrual cycles have been erratic lately. Vital signs are normal. TSH is 1.4. Which of the following therapies will most likely benefit this patient? A, tamoxifen, B, medroxyprogesterone, C, conjugated estrogen, D, anastrozole, or E, flutamide? All right. The answer here is B, medroxyprogesterone. So this is a woman with polycystic ovarian syndrome. More than likely, we would actually have to get an ultrasound of her ovaries to confirm that. But with polycystic ovarian syndrome, what you have is an obese woman, almost always it's an obese woman or mildly overweight woman, and you have androgenizing signs, and you have erratic menstrual cycles. So by androgenizing signs, I mean things like acne, things like hirsutism, truncal obesity, and by menstrual cycle erraticness, I mean either amenorrhea or oligomenorrhea. So she's not getting her period any more than either ever or no more than every 6 weeks. So the three cardinal symptoms or cardinal findings in polycystic ovarian syndrome are androgenizing signs, amenorrhea, oligomenorrhea, and then the polycystic ovaries on your sonogram. But the question here was which of the following therapies will most likely benefit this patient, and we have to, our presumptive diagnosis here, of course, we're not going to treat the patient without doing the sonogram because we have to get that to make the formal diagnosis. But what we can do here is we can rule out the fact that it may be caused from hypothyroidism, which may cause delayed menstrual cycles. So we know it's not that because the TSH is normal. And we've got the androgenizing signs, we've got the obesity, and we've got the oligamenorrhea. So those are all consistent with polycystic ovarian syndrome. What do we use in polycystic ovarian syndrome? The two best drugs are medroxyprogesterone or ethinyl estradiol. So the rest of these drugs are not appropriate for polycystic ovarian syndrome. And this would be the sonogram that would confirm polycystic ovarian syndrome. So I think the cutoff is 12 cysts that you have to see, and clearly there's more than that here. There's like almost 20 here. Okay, so let me just say though, you will normally see a couple of these cysts in an ovary. What these are just they're eggs getting ready to ovulate. But in women who have polycystic ovarian syndrome, the eggs sort of get ready to ovulate, but they just don't get there all the way. So that's why they've got multiple of them. Okay. Question 18. So a 42-year-old male presents to your clinic for annual checkup. Over the past year, he's gained 30 pounds and now has a BMI of 25.9. He's employed as a gym teacher at the local elementary school and says that he has been watching his diet, exercising as usual, but has been somewhat more tired lately. On physical exam, you note brittle hair, pallor, and decreased bowel sounds. Vital signs are normal. Which of the following is the best next step in the management of this patient? A, serum TSH level. B, low-dose dexamethasone suppression test. C, high-dose dexamethasone suppression test. D, lipid panel. Or E, iodine supplementation. And the answer here is A, serum TSH level. So this is a relatively straightforward question. The guy has weight gain, he's watching his diet, he's been tired, and he's got brittle hair and decreased bowel sounds and pallor. Those are all signs of hypothyroidism. Hypothyroidism is rather common. However, it's a little less common to show up in a man. But anytime you've got somebody with unexplainable weight gain and a person that's really watching their diet, and clearly this is a guy who's active, he's a gym teacher, he's watching his diet, he's exercising as usual, but he's got this weight gain and fatigue and particularly the brittle hair and the decreased bowel sounds. Those all point you towards hypothyroidism. And so you want to get a serum TSH level. We're not thinking Cushing's disease or Cushing's syndrome in this patient because he doesn't have the striae, he doesn't have a buffalo hump, he doesn't have moon facies, and so forth. Furthermore, a serum TSH level would be more appropriate because barring any specific signs of Cushing's disease, thyroid disease is far more likely. Lipid panel will eventually be appropriate in this patient because he does have hypothyroidism and because elevated cholesterol is associated with hypothyroidism, but we have to establish the diagnosis first. And iodine supplementation is appropriate in patients who have hypothyroidism due to endemic goiter, but that's not this guy. People in the U.S. very rarely have endemic goiter. And plus, we have to establish the diagnosis first, and that's done with a serum TSH level. Okay, 51-year-old woman presents to your clinic for annual checkup. As she is over 50, you recommend she get a DEXA scan to screen for osteoporosis. Which standard deviation is the cutoff to begin bisphosphonate therapy for osteoporosis? A, below -1, and these are T-scores, by the way. Below -1, below -1.5, below -2, below -2.5, or below -3. So the answer here is D, below -2.5. So the T-score is just a standard deviation from in bone density from the bone density of a healthy patient in their 20s. And so any patient who's who's 1 to 2.5 standard deviations below that level is considered to have osteopenia, and if it's below 2.5 standard deviations, then it's going to be osteoporosis. So here's 0, normal bone density, that's your control, and then -1 to -2.5, so t-scores, that's standard deviations below 0. That's osteopenia, and then if it's more than 2.5 standard deviations below normal, then it's osteoporosis. And we treat this with bisphosphonates, alendronate, abandronate, etc. Okay, final question. A 36-year-old woman presents to your clinic complaining of neck pain, which has been getting worse over the past month. Physical exam reveals a diffusely tender thyroid. No nodules are appreciated. TSH is 1.3, which is normal. Which of the following is the best next step in the management of this patient? A. Methimazole. B. Levothyroxine. C. Cyclophosphamide. D. Prednisone. Or E. RAI scan. All right, answer here is D. Prednisone. So this is a patient with de Quervain's thyroiditis. De Quervain's thyroiditis is the only thyroiditis that's painful. And so because this patient has a painful thyroiditis, we have to treat her with prednisone. So, that's done to reduce the inflammation. Now, with de Quervain's thyroiditis, it's an immune attack on the thyroid, so you will have an initial hyperthyroid stage, then you'll go into a normal thyroid stage, and then you'll go into a hypothyroid stage. She's clearly in the euthyroid stage, so we don't need to treat anything. We don't need to treat any thyroid-related symptoms. And de Quervain's thyroiditis is self-limited. So really all we need to do is try to reduce the inflammation, and we can treat her pain too. We would give her something like aspirin. But we don't really need to do anything but treat the disease itself. Now, methimazole, of course, that's for hyperthyroidism, so we don't use that. Levothyroxine would be if she were hypothyroid and symptomatic, which is not the case. Cyclophosphamide is way out. That's for autoimmune diseases like lupus and Wegener's granulomatosis. Prednisone is the best choice here. All right, and that's it.